Preterm premature rupture of membranes 20 to 22%, and another preterm deliveries indicated for fetal or maternal reasons, that is the iatrogenic type. So I would like to start the first question with Ravi sir. Ravi sir, a patient, a second gravida who has had a previous neonatal death at 26 weeks, now comes at 26 weeks with backache and pain in abdomen on and off regular and contractions. She gives a history of delivery at 25 weeks in her previous pregnancy. And how will you know whether she is in preterm labor or not?
I think it's very important for us to get a good history, because the history is the main key in which we are going to make the diagnosis. And of course, when we come to the examination part, we should be able to appreciate the uterine contractions. But sometimes many of us don't put our hands on the abdomen at all. So I think we need to do that. Clinical examination is important. And of course, we need to do a speculum examination to make sure that there's actually no concomitant leaking. Because if there's a concomitant leaking, then you may want to delay your digital examination. So I think it's very important for us to exclude leaking in a person who comes with what looks like preterm labor. And of course, if there is no leaking and you go on to do the examination and you actually establish there's a cervical dilatation of 3 centimeters or more, and of course, then you would proceed to do ultrasound, preferably a transvaginal ultrasound. And this is very important. The transvaginal ultrasound has to be done in the proper way, proper technique, with the patient being positioned correctly. If not, your measurements will be wrong. And we are looking at very, very tiny variations in the measurements. We're looking at 2 centimeters, 2.5 centimeters. So if your technique is wrong, you can actually get the wrong measurements, which we will look at later part of the talk.
Thank you, sir. So history and the physical examination is very important to exclude any other differential diagnosis like abruption or chorioamnionitis, which might be missed otherwise. So, Sushila madam, what points in her history will you take as relevant? She now has a past history.
Yeah, right from age, very young girl or elderly gravida, there is a good chance that she can have preterm labor. Then her nutritional status, the possibility that she could be low socioeconomic class, wherein there is a lot of physical labor involved, and the use of certain habits like smoking, etc. Now we get to see more and more women having alcohol in our community also. We had put it aside saying this doesn't belong to us. But then we do get to see, especially amongst the elite class. And then you move on to other, and if you look at the obstetric history, a previous history of preterm birth, there is a 30% increase in the chance of her having a preterm labor this time. And if there is a family history of preterm birth, and like I said, if she has had any uterine malformations, like a bicornate uterus or any other uterine malformation which goes on to midterm pregnancy, and a cone biopsy or any cervical surgery that she has undergone before, and multifetal pregnancy, like we had a discussion in the morning, twin pregnancy, they have a great chance of going in for preterm labor. Any bleeding from the genital tract early in pregnancy could possibly also be indicative of preterm labor. Malformed fetuses are more likely to deliver much earlier, and therefore we should keep that in mind also. Medical complications, any diabetes and other situations also can give rise to preterm labor.
So the single most important factor is
history taking is very important.
Preterm birth. And Bindu madam, how can you classify this patient who has had a previous preterm birth at 25 weeks? What sort of preterm birth did she have?
So we can classify preterm labor in terms of the gestational age and also in terms of the estimated fetal weight. This patient here, she had preterm delivery at last time at 25 weeks. So we can classify, she comes under the extremely preterm delivery. So how is the classification is like this. Most of our patients are coming under the late preterm. That is if they deliver between 34 to 37. 60 to 70% of our preterm births comes in that group. And the early preterm or the moderate preterm between 32 to 34 weeks. Very preterm between 28 to 32 weeks. Anything less than 28 weeks of gestation, it's known as the extreme preterm. So the perinatal morbidity and mortality increases as the gestational age falls.
So, Ravi sir, are there any reliable biomarkers, tests which you will consider for early diagnosis?
I think the only reliable biomarker that we have is what we go back to, again, a good history and your ability to do a good examination. I think this is very, very important because the patient is already coming to you with signs and symptoms of labor. And I think this is the time you're going to actually make sure that you're not missing an actual labor by looking at some parameters that are not reliable. So good history and a good clinical examination is what you have to depend on. And I think it's good to know that once a patient comes with preterm labor, we have to look at some of the basic investigations that you should do. And I think ultrasound is important. First a transabdominal, then of course you can proceed to a transvaginal ultrasound. A full blood count is good as a baseline because you do not know whether there's any infective process that's going in the background that's triggering off this preterm labor. And in my practice, we routinely do a speculum examination with a high vaginal swab to anyone who comes with preterm labor. And we grab this opportunity to actually do a GBS screening at the same time, which is routine. And then, of course, we would definitely want to look at the urine sample because we know that one of the commonest factors associated with preterm labor is urinary tract infection. So I think these are some of the things that you should look at doing when you see a patient coming in with what looks like a preterm labor.
So what about, can you elaborate on how do we do the TVS and what do we look in for that?
Okay, I think the important thing is you must make sure that before you do the transvaginal examination, you actually have the position of the patient appropriately placed. Most of the time what we do is we use a pillow to lift the buttocks up so that you have a good angle to manipulate your probe gently, not vigorously. And then of course, you have to make the right measurements. So in order to make the right measurements, you must be able to identify the structures within the image that you see. It's very important to have an empty bladder because the empty bladder will definitely interfere with the way you interpret the image and hence your measurements will be affected. So the internal os, if it's open, then the cervical length is measured from the tip of the funnel to the external os. It is not from the origin of the funnel. Yeah. So if you see here clearly, if you look at the picture with the blue background, you will find you do not include the distance of the funnel in your measurement. It is only, the funneling is left alone. The funnel length is not included in your measurement of the cervical length. So it has to be measured from the internal os right to the external os, and in this case, it is the measurement B. B is what will be your cervical length. If you don't do this, then you'll have a false impression that the cervical length is actually longer than what it actually is. And then you'll, of course, make the wrong diagnosis.
So we should not be touching the cervix and we should be looking the funnel width and also look whether the width of the cervical anterior lip is equivalent to the width of the cervical posterior lip also. Thank you, sir. And Sushila madam, how do we do routinely? Now sir told he is doing group B streptococcus screening in their community for all cases. Do we stop short of high vaginal swab or do we do rectovaginal swab for GBS culture every time?
We don't routinely screen for GBS. There are hardly a couple of papers in our in India about GBS screening. As of now, none of us are doing routine GBS screening for our pregnant women. Very rarely, if at all, there has been a previous neonate which has been affected by GBS, then we probably could consider GBS screening in our population. But I certainly don't do GBS screening on a routine basis. I also don't do a high vaginal swab for all women who come in preterm labor. If they have PROM, yes, I do a high vaginal swab. But if they have come just with preterm labor, there's no leak, then I don't do a high vaginal swab.
Okay. Dr. Bindu, the patient now is started to having regular uterine contractions. Cervix is 1 centimeter long and 2 centimeter dilated. So will you proceed to going to give tocolytics or not?
Yeah, she is having contractions. Regular contractions are there. And the length of the cervix is less than 2 centimeter, that is here only 1 centimeter, but the dilatation is 2 centimeter. That criteria is not strictly, it's more than 3 centimeter only, we will say it's the established preterm labor. So here she is having threatened preterm labor, but still since she is having regular contractions, I have to straight away start the tocolytics to abolish the contractions. And this patient, previously she had a spontaneous preterm labor. And if the patient already had previous history of any PPROM or any cervical surgery, this patient, ideally, we would have done the elective CERCLAGE between 14 to 16 weeks of gestation.
Now that she has come, what will you do for her? And now she's already 2 centimeter, Bindu madam. Will you go for a rescue CERCLAGE in this case?
No, initially I will go for the tocolysis. Initially the contractions has to be abolished. Then only because, then after that I have to go for the emergency CERCLAGE or the rescue CERCLAGE. Because the cervix is 2 centimeter, already 2 centimeter dilated, she is only 26 weeks of gestation.
So, Revisa, which is the tocolytic of choice if she is having a contraction of 5 contractions in 20 minutes?
I think we are aware of quite a number of drugs that we can use, but in our practice in Malaysia, at the present moment, our first line of drug of choice is nifedipine. The second is we look at the beta sympathomimetics, and the third, of course, we look at tractosile, which is otosiban, which is expensive. We have stopped actually using indomethacin for a while now. Both nifedipine and the beta mimetics, we actually have got special permission from our pharmacological unit in Ministry of Health, because the indication we are using is off-label. So for medical legal reasons, we actually have got permission to use both nifedipine and terbutaline for its non-indicated cause. As for otosiban, I understand it's expensive, but then we do have a budget for that for selected cases, and we use it as and when necessary. Indomethacin, actually, we don't use very much at all in our
Can
practice.
I make a point here? Yeah, in women with gestational diabetes and who have hydramnios and who go into preterm labor, indomethacin will be effective because not only does it bring down the contractions, it will also reduce the Leica volume. So I do indomethacin in those kind of selected cases. Otherwise, nifedipine would be my primary choice.
So 30 milligram followed by 20 milligram
Yeah.
TDS till the contractions are abolished. So, when you stop tocolysis, madam?
I stop tocolysis. See, my primary aim is to make sure that there is enough time for me to give the steroids and to make any preparations for transfer if it is required. Supposing it is an extremely preterm and my hospital is not suited to take care of this kind of a neonate, and I would want to transfer to an NICU, then I would want to buy time only to stop the contractions, to give the steroids and to make the transfer. Once I do that, I don't need to continue the tocolytic agents. Another thing is, supposing not every time that we give tocolytics, we are able to stop the preterm labor. Supposing I find that the dilatation is progressive, she is getting into active labor, there's no point in continuing the tocolytics at all. And in the process of waiting, sometimes if you see that there is either the maternal or fetal distress, or fetal distress for that matter, then there is no point in giving tocolytics. Action has to be taken immediately at whatever gestational age. So this would be my reasons for stopping tocolysis.
So there are certain contraindications, IUD, anomalies, chorioamnionitis,
Yeah.
and APH, where we are not going to give tocolytics at all. Bed rest, antibiotics, nutrition, sedation, homeonutrine monitoring, fetofibrinolectin, no use. So, Bindu madam, now she is 3 centimeter back of membrane, bulging into the vagina. Is it a contraindication for CERCLAGE?
No, definitely not. It's not a contraindication for CERCLAGE. But first thing, we have to abolish the contractions. The uterus is not contracting. We can do the rescue CERCLAGE up to 28 weeks of gestation. Before that, we have to rule out any rupture of membrane is there, whether the patient is having any sepsis, any bleeding. That is not the, we can do the CERCLAGE. So it is done with a non-absorbable suture material, that is the black silk we can use. If it is the ideal one is the muslin tape, that is the ideal. So it has to be done under general anesthesia. I think next session Pailisar is having a talk on that, so I am not going into the details of that one. But if you are doing, when you are doing the rescue CERCLAGE, if you got the enough cervix, you can try for the Shirodkar CERCLAGE. Otherwise, you can go for the McDonald's CERCLAGE.
So the next 10 questions, I think we'll be quizzing our experts. 10 more questions are there, so 5 more minutes only. So would you give progesterone in early pregnancy in these patients, sir?
I think progesterone has proved to be an effective ally in us trying to manage preterm labor. And I think if the patient has a short cervix and previous history of preterm birth, Vaginal progesterone up to 36 weeks is allowed, and of course we would like to have a CERCLAGE on board as well. In the asymptomatic patient, either singleton or in multiple pregnancy with short cervix, then vaginal progesterone supplementation has shown to reduce spontaneous preterm birth and hence improves neonatal outcome. So there's actually a paper out that says if you delay a preterm birth by 1 day, you increase the survivability of the baby by 3%. So I think that's important. Remember, that means even 1 day may make improvement. And of course, we know that FDA has removed 17-hydroxyprogesterone, but unfortunately, I still use. And I have been using it for a long time, and especially for my multiple gestations, either twins or triplets. We use it twice a week from 22 weeks on, and we have actually had quite good results so far.
Yeah, progesterones are coming back for preventing preterm labor and twin pregnancies. Now, antenatal steroids, definitely we need to give antenatal steroids in order to cut down all the complications that are likely to happen in the neonate. Now we have the choices betamethasone and dexamethasone. Both are equally good, but the betamethasone that we have in our country is a single salt betamethasone. What we need to have is a double salt of betamethasone phosphate and acetate. What we have here is only the phosphate, which is a very short acting. So if we have to use betamethasone in our country, with the available betamethasone, we have to give it 12-hourly 4 doses. So if you are going to give betamethasone, you have to give it 12-hourly 4 doses. Whereas if you have to give dexamethasone, you give the same thing, 12-hourly 4 doses. Earlier, if you are having the double salt of betamethasone, you can give just 2 doses, 24 hours apart. But since we have only the single salt of betamethasone, it's a short-acting betamethasone, so you need to give 12-hourly 4 doses.
Neetha madam, what's the role of magnesium sulfate in imminent preterm labor?
So magnesium sulfate, less than 32 weeks of gestation, and there is imminent preterm labor, we have to give magnesium sulfate for the neuroprotection of the baby. So it decreases the incidence of cerebral palsy and the severe motor dysfunction in the neonate. So same dose, just like as we are giving for the eclampsia, we have to give. That is the 4 gram IV over 20 minutes, followed by 1 gram per hour, for till the patient delivers, or for 24 hours maximum, whichever is earlier. But after some time, after starting the magnesium sulfate, if the patient stops contraction, then we can stop the magnesium sulfate, and after 1 week, again the patient starts contractions and imminent delivery is we can restart the magnesium sulfate. But remember, always maximum 24 hours only we have to give magnesium sulfate. If we give more than 24 hours, it can lead to fetal osteopenia.
So among the preterm complications, Revisa, which do you encounter most in your setup?
I think the most important thing is 2 things when you look at preterm labor. One is we want to prolong the pregnancy so that the better fetal outcome. But of course, when you have no choice, we have to accept that there can be fetal complications. These complications can be short-term as well as long-term. And I think it's very self-explanatory here. And I remember once upon a time when we used to give oxygen therapy, then we have the baby who is alive, but who ends up blind. So I think these are important things. And in my country, one of the biggest problems we have is that with preterm deliveries is we are getting sued left and right and center for cerebral palsy. We just lost a case 2 months ago where we lost 7.8 million. This is a government case. So I think these are things that despite telling the patients, counseling them, we still end up with these things. So these complications has to be very clearly told to them.
Sushila madam, can you tell about the labor management?
Yeah, this is a preterm baby that we are going to receive. So we should make sure that our facility has the capacity to take care of such a kind of a newborn. And if it doesn't have, it is best to ship the mother with the baby rather than to ship the baby. And then, of course, if required, we might have to use an instrumental delivery. Instrumental delivery would be better to protect the small premature head. It would be nicer to use the smaller forceps, Dr. Piley's forceps as you mentioned. Vacuum should not be used in a preterm delivery. That is one definite point that I would like to drive home. No vacuum use because it's likely to be dangerous to the baby. It can cause subgaleal hematoma, etc. And cesarean section is only for this one. Now, a preterm baby, we are all talking about late cord clamping. late cord clamping, if the baby is healthy, even in a term baby, would prefer to do a late cord clamping. But in a preterm baby, it is even more useful. And if the baby is come out well, it is worthwhile clamping the cord late, or at least you could milk the cord. That is, hold the cord, clamp the cord about 10 centimeters from this one, and then milk the blood that is there in the cord towards the baby, so that the baby gets that much extra blood. And that goes a long way in helping the recovery of the neonate.
So one last question. What is about the pre-PROM patient comes to you at 30 weeks, Ravi sir? Can you just, can he finish this one? PPROM at 30 weeks. Ravi sir, can you just tell what you will look for?
The most important thing is that we have to admit the patient, get a good history as we have decided, get your vitals, examine the patient, again examine the patient, determine that there's fetal heart present, because the fetal heart is absent, then the whole game changes. Then of course, make sure there's no leaking, then do a per speculum, look at the cervical state, and then we will not do a vaginal digital examination unless we are thinking of progressing further. Then of course the investigations we have decided, and we can start them on antibiotic. The practice here is erythromycin 250 QID, but in my country we use EES, erythromycin ethyl succinate, 400 milligram BD. It's better on the gut because it's sugar coated. Then of course we have the rest of the antibiotics that we have here that you can use, and then consider corticosteroids and magnesium sulfate. And of course at the same time look at the transfer of patient if there has to be a higher level of care. And not totally accept to cover time for steroids and magnesium sulfate. That means we are just protecting the baby and then we are deciding what to do next. If patient is not in labor, no signs of sepsis, and the surveillance is good, then we can look at prolonging the pregnancy.
Yeah,
So-
I would like to say that in case it is a high leak and the leak stops, you've given antibiotics, there is no evidence of sepsis, you can, she's not going into labor, she has settled very well, you can even send her home and ask her to report if there is, of course, under surveillance. You ask her to, you keep her under close monitoring, but there are women who have had initial leak, settled, and then they have gone home and come back in labor much later. So it is good to prolong such pregnancies where there is
So
no
at least
infection.
36 completed weeks we'll try to look for, and in chorioamnionitis we have to start the triple antibiotics and try early termination.
Yes,
We
yes,
should not be
yes.
prolonging. Thank you. Thank you, Deepthi, for giving that extra time.
Neetha, thank you so much. Thanking the whole team. Please take the photo. Now the last session before lunch. I realize that lunch is a very good appetizer. I mean, the announcement of lunch is a good stimulator to finish it on time. Antepartum hemorrhage. May I now invite Dr. Megha Jayaprakash, Professor from Thrissur Medical College, and the faculty, Dr. Chitra Madam from Coimbatore, as well as Dr. Sajala Vimalraj, Professor from Calicut Medical College. As they are getting ready, Dr. Serena has a few points to announce.
Friends, I take this opportunity to invite you all for FOCUS, all the postgraduates. It's between August 21st and 20th.